2-year-old boy is rushed to the emergency department in the early morning by his mother because he was unresponsive to deep pain stimuli. The patient mother said he has been suffering from fever, cough, runny nose for past 2 days. The 2 days ago, he visited a free clinic and received an aspirin. When he gave him aspirin yesterday, he had 3 episodes of vomiting and condition rapidly worsened. This morning, patient did not wake up, and even with multiple attempts on physical examination, he was afebrile, hypotensive, and tachycardic. The peripheral pulse was +1, and extremities were pale and cool to touch. The pupils were equal and slowly reactive to lights. Significant hepatomegaly is noted. Which of the following is most likely etiology of this patient's symptom? So the last question and this question is very similar. Yes. And this is also decrease in beta oxidation. And yes, someone wrote the right answer. The patient is suffering with Rey syndrome. That is a young child that received an aspirin, and that causes them to have hepatic failure or hepatomegaly due to decrease in beta oxidation. So let's go through this explanation. You can see whenever patient have viral infection and he or she children receive aspirin, there increased risk of having Rey syndrome, and Rey syndrome is classically classified presents as fulminant hepatitis or rapidly progressive hepatitis, or patient can have cerebrum edema, that is altered level of consciousness and behavioral changes. You can see in this table the pathophysiology of Rey syndrome is when we give aspirin to children during any viral infection in influenza or varicella, and it causes them to have microvesicular fat deposition into the liver. Remember, whenever we give aspirin, or we can there is a image for that. Yes. So the pathophysiology is basically when we give aspirin, it uncouples the oxidative phosphorylation, that is a process of formation of ATP in the cell, and this causes them to have decrease. So whenever there is no ATP, so there is a decrease in the beta oxidation of fat, and there is decreased oxidative phosphorylation, and this causes decrease in ATP, causes decreased function of mitochondria and decreased function of beta uh, oxidation, and causes accumulation of fat into the liver cells, and this causes microvesicular vacuolization into the. This is very rare and it usually occurs between ages from 4 to 12. So you can see patient might have cerebellar edema and acute. The clinical features are acute liver failure, which can present as hepatomegaly without jaundice, or it can have rapidly progressive encephalopathy like vomiting, lethargy, seizures, and coma. What are laboratory findings? Laboratory findings are increase in AST and ALT and ammonia, They can have increased PT, INR, and PTT. Patient can have decreased glucose. They can have metabolic acidosis and normal bilirubin, and treatment is supportive. So we can, what is the one condition in the children we have to remember where we can give aspirin without having to risk patient of having, which is no, yeah, it's a Kawasaki's disease. And what in the Kawasaki disease mostly we are concerned about, so we give aspirin. So in Kawasaki disease, the children can form coronary artery aneurysm. So yes, cardiac complications, like most common is coronary artery aneurysm. So they form a small aneurysm in the coronary artery of children. So in that we can give aspirin, because this we are risking benefits outweigh the risk. So benefits is greater than risk, so we can give aspirin in this patient with Kawasaki disease. Okay, so you can see in the gross autopsy of liver, children who died of Ray's syndrome, and they have slight pallor and they have fat accumulation in the liver. You can see right here. Ray's syndrome is usually associated with fatty liver, hypoglycemia, and coma, and it's also linked with children hepatic encephalopathy. And the alternate drug can be used is acetaminophen instead of aspirin.
Thanks for watching. Please give a thumbs up and subscribe for more.